actually think that I would be a school teacher.
Well, I've always been fascinated by science, so I think I would be a scientist.
And I think I would be an historian.
And I probably will be cooking somewhere. I do enjoy the cooking process.
A little about me personally, I have 3 kids and a dog, and so my house is a zoo all the time, which is really fun.
Is that I would really recommend that you also in your professional life, that you do things you really like to do in life and in your profession.
20th century is Tom Wolfe. I think his best book was Bonfire of the Vanities.
Do I have any collections? And I have a weird collection which I collected from when I was a kid, and those are Asterix and Obelix comics.
The other thing is, do I have any collections? The answer is yes, I do. I have a couple of note. One is that I have a very extensive baseball book library that's really quite impressive, and I've read all the books that are in there and continue to grow that. And then I have a bobblehead collection too, and I've had these bobbleheads given to me by patients over the years. They know I collect them. I have a few interesting bobbleheads as well from friends, and there's even a bobblehead of myself that a patient had made for me. So those are a couple of the collections that I have and truly enjoy.
That's patients and people. And the reason I say that is my focus in my career has been on identifying new targets, developing therapies, and then testing them in clinical trials. And nothing is more gratifying than to see patients for whom their options have become fewer, and now we have something new, and seeing those new therapies making a difference for people.
I really see a lot of value in support groups, so I'm often encouraging my patients to join different support groups, and it's one of my favorite things that I do in my job is to bring patients together to talk about things that are important to them.
To help patients suffering from this lymphoma subtype, because we know that Waldenstrom's macroglobulinemia can cause a lot of different symptoms, and many of them are really able to compromise quality of life. So this was my ambition and my motivation.
My career on Waldenstrom's, and I will have to admit that it's been a more recent change for me. A lot of my practice is focused on multiple myeloma, but through the course of my years at the Fred Hutch Cancer Center, have had the opportunity to meet a lot of patients with Waldenstrom's and be mentored by a mentor who focused on Waldenstrom. And so that's what compelled me to focus my career that way.
This misconception people have about your position. I think there are a couple of 2 big misconceptions. Number 1 is that I don't sleep. And the number 2 is that I know everything. I do sleep and I don't know everything.
I think what compelled me the most was the complexity of your disease. It's not a straightforward disease at all. It is a very complex disease with many different angles to look at it, and also many uncertainties at the moment. We don't know all of it. We will never know all of it. But I think from every patient I still learn, because the disease can be so diverse, and that's something I like.
In terms of just understanding a work lesson that I've come away with over the years, and it has to do with patient communication. For patients to have trust in your recommendations and willing to comply with some of the suggestions, some of which can have significant risks, it's really important that you establish adequate communication with your patient. And by that, I mean getting away from the jargon and the technical lingo that physicians so often fall into.
Very early in my career, I was actually exposed to the care of a patient with Waldenstrom's who had received the first biologic therapy, that being rituximab. And I was actually quite excited about the use of a biologic agent instead of chemotherapy to treat Waldenstrom's macroglobulinemia. And this actually embarked me on studying rituximab in Waldenstrom's, not only studying it both as a clinical agent, but understanding from a basic science point of view how rituximab work. And I think much of that work not only applies to Waldenstrom's, but also to other diseases that use rituximab.
Professional perspective, What influenced me to become a WM physician? Well, I've always been, throughout my whole medical life, interested in blood cancer and hematology. And believe it or not, I went to a hematology conference in the early 2000s. It was in Whistler, BC. And I was on a bus between Vancouver and Whistler and sat behind this other physician who was, right in front of me. We were chatting about what we did. And I explained, I see these patients. He goes, well, I'm interested in Waldenstrom's. I said, well, I have some of these patients. I'd love to become more involved with Waldenstrom's and so forth. And that physician who was sitting in front of me was named Dr. Stephen Treon. And Dr. Treon got me involved from that moment on in what initially was called the WM Clinical Trials Group. And I've been fortunate enough to be able to be involved in WM.
For me, it's very important that all patients know this and that they should look in an optimistic way into the future.
And for me is that your M protein, every patient should know their M protein, but you should also know that your M protein is just a number.
Is that these are very exciting times. We know more about Waldenstrom's than any other point in history. We understand now much of its genomics, although there's much more to be revealed. But I can tell you this is actually steering us in a direction that we couldn't have even imagined even 10 years ago. One, to developing new therapies that are truly targeted and genomically driven. And the other, I think, which is just as important, is individualizing treatment for patients and not really presuming that all Waldenstrom patients actually are the same. They're not. We know that already. But if we have a genomic footprint for each patient to guide us into using many of the new drugs and drugs to be developed in the future, I think this is the excitement that I want to be able to share at this year's forum.
One thing that I would want all patients with Waldenstrom's to know is that it's a long game. You probably know this already, but if you have a precursor condition, chances are that you would be followed by your oncologist for a long time, maybe even before ever needing treatment. And even once you start treatment, that it's something that we're following and treating for a long time, years maybe.
You should be hopeful. Our treatments are so good and the disease responds so well to our treatments that our hope is for excellent quality of life and long survival. So go WMers.
It's just how important it is to make sure that you don't feel isolated during this process. So whether it's reaching out to a therapist, using social media, connecting with friends and family, really making sure that they reach out and get the support that they need.
That Waldenstrom's is changing fast, and it's changing for the better for everybody. We now have many treatment options. Many of those treatment options are far better tolerated than in the past, but more interesting and more exciting is those new options are making a huge difference in patients' longevity, and many patients now are having a much better outcome with Waldenstrom's overall.
I think it's important to know that this is a journey. It is a marathon. It's not a sprint. So I think a few things, how you arm yourself to something like this. You need to have mental strength, you need to have physical strength, you need to have a network of people around you. So sharing with people that loves you, being in the visits with the people that care about you, I think is very important. Educating yourself, arm yourself with all the knowledge that you can so you can be your best own advocate. I think that's actually a very important message that I can provide as well. So always thinking in the long term.
Is not focus on the level of the IgM. The IgM level, which we use as a surrogate of disease activity, is not really used in decision making. There's no threshold above which we're going to recommend treatment. We do follow trends over time, but for example, a certain level of IgM does not determine whether we need to do something about it. Those decisions are made primarily on patient symptoms, and so you should be focusing on how you're feeling, the quality of your life, and your activities of daily living rather than what my IgM level is.